Hi, good evening and welcome. I'd like to thank everybody for attending our Are You Really Hot webinar tonight, where Dr. Sam DeLuca will be helping us discuss all the issues related to menopause. I'm Laurie Trongone. I'm the Assistant Vice President for Women's and Children for Inspira Health. And we have a great presentation again for you tonight. So I'd like to talk about a few things we need to go through. We are using the On24 platform again tonight. It's interactive and allows you to resize and move the icons on your screen. We want you to be able to get the most out of your experience, so make it personal and make what works for you on the screen and being able to see what you need to see. You could also enlarge the slides by clicking on the arrows in the top right corner. And you could actually make an online request for appointment right on your screen. At the bottom of your screen, there are multiple engagement tools you can use. And using the toolbar, you'll be able to download the slides. There's a menopause fact sheet in there, and there are other resources as well as Dr. DeLuca's speaker bio. As usual, we encourage you to ask questions throughout the event using the question and answer button. Your questions will only be visible to our presenters, and your identity can be anonymous if that's what you'd like it to be. With that in mind, we hope you feel comfortable and ask whatever's on your mind. Throughout the presentation, you'll see poll questions pop on your screen. All your responses for this will always be anonymous, and we encourage you to participate. We usually have some fun with the poll questions, so enjoy that. Once again, this presentation is being recorded, and an on-demand version will be available tomorrow using the same audience link that you used tonight to enter. It is once again my privilege to introduce tonight's speaker, Dr. Samantha DeLuca. She's an obstetrician and gynecologist at Inspira Medical Group's Obstetrics and Gynecology Mullica Hill and West Deptford practice, and she's also in Washington Township now. She earned her undergraduate bachelor's degree from the University of Pennsylvania and her medical degree from the Philadelphia College of Osteopathic Medicine. She completed her residency at ChristianaCare Health System in Newark, Delaware. In 2009, 2014, and in 2019, Dr. DeLuca was named a top doc in South Jersey Magazine. In 2011 and in 2013, she received the Compassionate Doctor Recognition Award. She has special interest in menopausal medicine, which is why she's speaking with us tonight, infertility, and medical and surgical interventions for endometriosis. So welcome, Dr. DeLuca, and thank you for taking the time with us tonight.
My pleasure.
So we will start with a poll question that the audience involved right away. And we'll start at the beginning. Can you get pregnant after menopause? True or false? Can you get pregnant after menopause? I'll give you a couple seconds to answer the question, and then we'll be able to talk about this throughout the presentation. Let's see. So about 67% of our audience says true, you can get pregnant after menopause, and about 33% say false. So there really are 3 stages of menopause. We'll start right at the beginning here. Many women experience what is called perimenopause first. That's the transition to menopause, and that's when your hormone levels begin to change in preparation for the actual menopause. So women experience menopause and postmenopause as well. The quick answer to this question of whether women can get pregnant after menopause is no, but we will let Dr. DeLuca walk us through what this means and physically why you cannot get pregnant. So we'll have her start at the beginning.
So
Dr.
the beginning is perimenopause, and people are, familiar with this, sometimes called climacteric, and most recently we've been starting to call it the menopausal transition. Basically, this period in a woman's life is marked by hormonal fluctuations, and it's sort of like the ovaries having their last hurrah, getting the last bit of estrogen out of there before they finally go to sleep. And really, menopause is cessation of ovarian function. In other words, your ovaries stop producing estrogen. So this perimenopause, it can occur for a long time. It can go anywhere from the average age is 45 to 55. Some people say it's 4 or 5 years long, but some people never, ever have perimenopause. They just stop their period, and that's that. They never have any symptoms. symptoms. One thing that most people do notice about perimenopause is their periods are different. So if you've been the type of person who's had a regular period, get it every single month, 5 days long, no issues, you may notice that you're skipping periods, or that you're getting periods that are closer together, like every 2 or 3 weeks you're noticing you're getting your period, or your period's in a hurry to get out. You know, you bleed heavily for 2 days and then it tapers off over the next 4 or 5. And that's all a function of perimenopause, where you're getting those light or heavy cycles depending on the fluctuations of estrogen. Like a bunch of estrogen gets kicked out from the ovaries and then it stops, and then a bunch more gets kicked out and it stops. And that can also lead to symptoms of breast tenderness with your period, mood swings, migraine headaches, and different things like that.
So I've also heard about premature menopause. Is that a real thing?
It is, and actually it's a little bit different than the menopause that we're talking about tonight. Premature menopause, or premature ovarian failure, occurs in women who are less than 40. And it's a real issue because their ovaries completely stop producing estrogen at a very young age. And that's an issue because, you know, once you lose estrogen, your bone, your brain, and your vagina really suffers. And somebody who's so young losing their estrogen, it can be a significant lifelong issue. We know that there's certain risk factors for this premature ovarian failure, which occurs before the age of 20. And that is anybody who's had surgery to remove the ovaries, of course, a surgical menopause, will go through premature menopause as soon as we take out the ovaries, as well as sometimes with a hysterectomy, people will go through. People have this issue that runs in their family. If their mom had premature ovarian failure, they could have it, or their sister. And then other risk factors are chemotherapy. If you're receiving any kind of treatment for other kinds of cancer, that could stop your ovarian function as well and give you premature ovarian failure. And sometimes autoimmune disease like inflammatory bowel disease or rheumatoid arthritis. Women with HIV/AIDS sometimes go through premature ovarian failure. And it's a little bit different of a phenomenon than the focus of this talk tonight.
So you've said that menopause is the spontaneous permanent ending of menstruation. So natural menopause then is that cessation that's not caused by any medical treatment. Can you tell us a little bit more about what actual menopause means for us?
Sure. I mean, if perimenopause is the years leading up to permanent cessation of your period, menopause is actually when you haven't had your period for 12 months. You have to have 12 calendar months of no period. If you got your period on the 11th month, guess what? You got to start all over again. You're not in menopause. So it really is 12 months in a row. In this country, and it's really dependent on your geographic location, in this country, the average age of menopause is 51. So that can mean anywhere between 45 and 55, or even between 40 and 58. There are women who are still in their late 50s getting their period. A lot of times there is a familial association. Like if your mom and sister went through early, you might go through early. If your mom and sister had long menstrual life and, 55, 56 they're going through, that might be your fate as well. Smokers tend to go through about 2 years earlier. Just because of the effect that the carcinogens of smoking have on the ovary. And you can no longer get pregnant when you're in menopause. So if you've had 12 months of no period, you're considered in menopause, and the risk for pregnancy is gone at that point. The menopause is characterized by low levels of estrogen and progesterone, and also low levels of testosterone as well.
So 12 years is giving me a hot flash. It's not enough 12 months.
Oh.
No. So let's ask our audience another question. And that is true or false. All women experience the symptoms of menopause the same. So we'll give everybody a few minutes. Or not minutes, we'll give them a few seconds, and then we will have you tell us whether or not it's true, and if we all go through exactly the same thing, or if perhaps some of us go through things a little bit differently. Well, I think we have a very bright audience tonight. So 100% of them say false, that we do not all experience the symptoms of menopause the same. So why don't you walk us through that?
So that's absolutely true. Every woman is different. And there's some women, like we said earlier, who really just go through menopause. They stop their period and they never look back. Those women are infuriating. No, I'm just kidding. Most women have some symptoms of estrogen deficiency or estrogen loss. And, going through menopause, like I said, we have these hormonal swings. Like normally your cycle, the estrogen level goes up, you ovulate, the estrogen level goes down. When you're going through perimenopause and menopause, your estrogen levels are very, very high in response to the brain trying so hard to get estrogen out of your ovary. And then they're very, very, very low. So they go up and down and up and down. And that can lead to things like irregular periods, like we said, heavy periods, frequent periods, hot flashes, and night sweats. The most extreme form of, this is the most extreme form would be at night of night sweats. But hot flashes are the sensation of heat that builds from the middle of your body and kind of washes over the top of your head. And women describe this like ball of heat inside them that goes up and over their head and down. And they can cause a woman to sweat. I mean, you might be changing your clothes a couple times a day. When you're sleeping, you might have to change the bedclothes. I mean, very, very significant, symptom of menopause. Also, you're hot flashing all night, you're not sleeping. We recommend women get 8 hours sleep a night, but if you're up every 2 hours having hot flashes, it's very difficult to sleep. And lack of sleep can affect your concentration. It can affect your feeling of well-being. There's also, with the loss of estrogen, the changes in the vaginal area, and that can be loss of interest in sex as well as dry or painful sex. There's something that we used to call atrophic vaginitis or vulvovaginal atrophy, which is now called the genitourinary syndrome of menopause. And what it consists of, about 6 years after menopause, it peaks. And it consists of vaginal dryness, painful sex, burning in the vaginal area, and sometimes even symptoms of a urinary tract infection where you get really bad burning when you urinate. So that's from an extreme loss of estrogen in the vagina as well. Women complain of breast tenderness from these hormonal swings. When the estrogen levels go really, really high, can stimulate the glandular tissue in your breast and cause soreness and tenderness. Women universally complain of weight gain as they're going through the change of life. And that's because of estrogen's effect on your metabolism. And even if women are exercising and eating the right foods, they feel like they're gaining weight, and it's very frustrating. And then there's some, not so common things that people don't think about when they think about what's going on with their body, like difficulty concentrating, word finding difficulties, itchy skin or dry skin, hair loss. You might see like a little animal in your drain, from your hair falling out. Some people complain of joint pain. They have difficulty getting up, or they have extreme joint pain, anxiety, depression, and just a sense of fatigue. Those are all symptoms of menopause. Also, people can experience things like gum problems and periodontal disease as well.
Well, that all sounds really lovely.
That's good news.
So let's ask our audience what they think is the most disruptive symptom of all those symptoms we talked about. Is it hot flashes, mood swings, night sweats, or weight gain? And for those of us who are experiencing these, I'm sure we all have a preference as to what's the worst of them, since nothing is totally pleasant. So we'll give people a few seconds, and then we will see what people think is. So 50% think hot flashes are the most disruptive symptom of menopause, and 50% think weight gain is. I personally think all of them are just lovely. Hot flashes can be either, any of them I think are disruptive, but sort of nationally what people feel like is the worst are the night flashes or the hot flashes at night. As you mentioned, it really does disrupt your sleep. I haven't had a full night's sleep since I was 40. And then a close second is the weight gain. And then, so people are right on target, right? So 74% think hot flashes nationally, and 69% think weight gain nationally. So our audience is right on. And then, so hot flashes, and then night sweats, and then mood changes. So again, our audience is right on target. And then, we do have some other effects and symptoms. So you want to just walk us through what some of those are?
Yeah, sure. So, we talked already about sort of the perimenopause and the different things, and now the menopause. And, really, once you get into menopause and you've lost your period for over a year and you've lost your estrogen, there are some things that start to happen. So the most, I would think, and I do think this is what is commonly said, is that the effects are most common on the bone and the vagina. So they're most pronounced. So once we lose estrogen from our bone, then we're at risk for osteoporosis. And that is a common thing that happens in menopause. And then in terms of our vagina, like I said before, not to emphasize the vagina, but that is one of the organs that we have that is most sensitive to loss of estrogen. So a lot of the side effects and a lot of the complaints that people have after menopause result from loss of estrogen in these organs, as well as your brain. The brain fog that you get, the difficulty concentrating, that's also an organ that's very sensitive to estrogen. But less noticeable effects are things like change in your lipid profile, change in your cholesterol, and the fact that your cholesterol profile is not as good can result in heart disease and risk for heart attack and stroke. So those are concerning things. Also, we talked a little bit about urinary incontinence. A lot of times, in menopause, that loss of estrogen from the vagina can contribute to urinary incontinence. Mood changes we talked about, also changes in your eyes and changes in your mouth, periodontal disease and cataracts.
Okay. Thank you for that. And as women, we all experience some or all of the symptoms and the timeline that you discussed. How do you diagnose it? Like, I know we have the symptoms and we think, okay, this is what we are, but do you have a definitive way to tell us, yes, you're in menopause?
Yeah, so we talked about the cessation of your menses for 12 months, and that's important because there are some women, say, for example, that have had a hysterectomy, or some women that have had an endometrial ablation where they don't get their period anymore, or some women who have been treated for breast cancer with tamoxifen and don't get their period. It's really hard to tell. Are you in menopause or are you not in menopause? It's just because, is this just because I don't get my period anymore because I had an ablation? So there are a number of ways that we can find out biochemically if the lack of your period is due to menopause and ovarian failure. The most common way that we do it is by two blood tests. One's called FSH and one's called estradiol. And FSH is the follicle stimulating hormone. It is the brain chemical that is released to try to stimulate the ovary to produce estrogen. So when FSH gets very, very high in the blood, what that means is that the ovary is not responding because the brain is working overtime and producing lots of this FSH to try to wake up the ovary. So menopause is characterized by high levels of FSH in the 25 to 30 range and low levels of estradiol, or the ovarian estrogen, in the 10 to 14 range. And that's typically how we diagnose menopause in the setting of no period for a year. But there are new tests coming out. There's a new test available in the market called the PICO AMH ELISA test. And AMH stands for anti-Müllerian hormone. Anti-Müllerian hormone actually measures the primordial follicles in your ovary. So before you ovulate an egg, you have a follicle in there. And the more follicles you have, the better your ovarian reserve is, i.e. the farther away you are from menopause. The AMH test, if it's non-detectable, that means that it's a good sign that your ovaries have stopped working and that there's no follicles left, and so you're in menopause. Additional blood tests that we do, just to be sure that there's no other reason that you could be not getting your period and that it is menopause, would be a test for pregnancy, like an HCG test. You can still get pregnant late in your 40s, even though you think, oh, I haven't had my period in a year, you could be pregnant. The thyroid function tests are really important because thyroid disease, like hypothyroidism, can give you symptoms of not getting your period or amenorrhea, as well as anxiety, palpitations, some of these hot flashes and sweats that we're talking about. So you want to exclude a thyroid disease. Prolactin is a brain hormone that is released in high concentrations when there's a pituitary tumor present, and that can also give you lack of a period. So we do check for prolactin as well. And some of the other tests that are listed here are important to exclude other metabolic causes of not getting your period.
So the obvious question then is, what can we do about any or all of these symptoms? Are there any treatment options that we have available?
So it definitely depends on which symptoms you're having. I mean, if you're having minimal symptoms and just kind of brain fog or weight gain, you definitely can do things, like, just kind of dietary and lifestyle modifications, as well as herbal modifications to try to alleviate some of the symptoms. But some women are debilitated. They're having hot flashes that are terrible, or inability to sleep, or debilitating anxiety. I've had patients come in and say, I was fine. I used to travel across the bridge every single month to go to my job, and now I can't go across the bridge, and I have so much anxiety about it. What do you think is wrong with me? And some of these things, you really do need to pursue aggressive treatment, either with hormone replacement therapy or with other medications.
Are there any tips that you might be able to share with our audience on how to navigate through this multi-year and sometimes difficult process, as you've mentioned, that our bodies are going through?
So I usually start my patients with just lifestyle modifications and diet modifications. So, just things you can do to try to keep cool. Carry one of those little portable fans with you, or hook it to your key ring. And if you start to feel you're getting a hot flash, just kind of blow the cool air on yourself. When you get into your car, make sure all the car vents point to your face, and turn on the air conditioning a little bit to break a hot flash. People want to they're freezing when they go to bed sometimes, and they have all these covers. Well, don't wear socks and keep one of your feet out of the covers, just to kind of wick away some of that, that heat that you're experiencing. Dress in cool clothes, short sleeves with layers, so that if you get hot during the day, you can take off your jacket, and if you get cold again, you can put it back on. Keep your bedroom area cool, a ceiling fan or an air conditioning unit, just so that you can get through the night without waking up 10 times. Avoid heavy blankets, and they even talk about waterproof sheets or wicking material in your pajamas that can help. Exercise and weight management. Exercise doesn't really help hot flashes, but exercise and reducing calories can definitely increase your energy level. It helps you sleep. It can help with well-being, and it helps your mood. So it really is recommended to do those things.
So are there any supplements or things that we can do to decrease some of our risk?
Well, we talked about the risk of osteoporosis, and even though somewhat controversial depending on a woman's risk factors, we still recommend calcium and vitamin D to help prevent bone loss. Calcium, we typically tell women 1,200 milligrams a day, with vitamin D at least 1,000 international units a day. You can buy calcium and D supplements together that combine both of these and take 1 or 2 pills a day to help. If someone has heart disease or someone has renal disease like kidney stones, they may not be a candidate for calcium. So I would always have a woman check with her primary care doctor or with her healthcare professional before she starts calcium to be sure there's no contraindication. Magnesium can help with constipation, especially if you have calcium-induced constipation, and that's also recommended too in postmenopause.
Yeah. And I've read that 400 is the calcium
Magnesium
requirement. So you said 1,200 milligrams a day for calcium, 1,000, what is that, international units for the vitamin D, and 400
for the magnesium. Yeah. Yep. Absolutely.
So thank you. Yeah. So what else can we do to help get us through this difficult time?
So, relaxation techniques like yoga and breathing techniques, massage, meditation. Definitely want to take care of your skin, moisturize. Be careful to avoid harsh products or harsh soaps, which can cause itching and dried skin. Definitely want to manage sleep issues. Natural sleeping aids can include anything like melatonin, Tylenol PM, Benadryl. Definitely like over-the-counter products like St. John's wort to relax you, or herbal tea. Milk can help, or even essential oils like lavender can help you fall asleep. Smoking and alcohol are really, really not recommended for this time of life, because they can definitely make these situations worse, and you have to limit the alcohol you're taking as well as quit smoking.
Yeah. So every webinar we've done so far, or even when we were doing in-person events, smoking comes up as one of the things, that we need to recommend to people to quit, because it just so impacts your health and well-being. So thank you for that. So we do have the North American Menopause Society, which is a nonprofit organization that's really dedicated to promoting the health and quality of life that all women experience during midlife and beyond, and it helps us to understand menopause and healthy aging. So NAMS, as the acronym is called, their members include people in various fields. So whether that's nursing, sociology, psychology, the physicians, nutrition, anthropology, epidemiology, there's pharmacists involved, and educators as well. So that really, having such a diverse group of people as part of the organization really allows them to be uniquely qualified to help provide information to us that's both accurate and unbiased. So NAMS has some suggestions and solutions for some of the symptoms that we experience. So you want to walk us through what some of those are?
Sure. I do also want to, give my support of NAMS. NAMS is a wonderful organization, and they have professionals from all over the world that come together at the NAMS meeting and really do all this research on these things that are impacting women in menopause. It's incredible. If you go on Google or YouTube and you look up any subject that you want to know, genitourinary symptoms, syndrome of menopause, or if you look at bioidentical hormones, it's all on there. And they really have respected researchers in this area that are coming up with evidence-based suggestions for the world. It's really incredible. So I do really support NAMS, and I am a member of NAMS. NAMS recommends for mood changes, like we were talking about before, being good to yourself, relaxation techniques, exercise, meditation, yoga, deep breathing, self-nurturing, really trying to reduce the stress in your life, and then herbal treatments that you can use over the counter, like St. John's wort, vitamin B6, those kinds of things to help with mood changes of menopause. Urinary incontinence gets a little bit more frequent when you get into menopause. And you definitely want to try to avoid caffeine and alcohol, because caffeine especially can cause bladder spasm, which can contribute to urinary incontinence. Also, timed voiding. Like, all of us try to hold our urine till the last minute and then try to run to the bathroom after, not going for 6 hours. Try to go to the bathroom every 2 to 3 hours, because really when your bladder is full, you're more likely to have leakage or have urgency, which is troubling. You want to avoid harsh food or foods that can be harsh to the bladder mucosa, like anything citrusy or spicy, if you're having any issues. And then we talk about the Kegel exercises. The Kegel muscle is the muscle that you'll find if you go to the bathroom, you go pee, and then you try to stop your urinary stream. Don't contract your buttocks up. Just use the muscle to stop the urinary stream. And that's your Kegel muscle. And I tell patients to do Kegel exercises 10 times a day, hold for 10 seconds. 10 times in a row. And that is hard. That is hard exercise because it's hard to hold that muscle for 10 seconds if you're not practicing. But you're online at the bank, you're at a red light, you're washing dishes, you're watching TV. Just contract those muscles and practice that Kegel muscle. It will not only help with urinary incontinence, it also helps with pleasurable sex as well. For night sweats, NAMS recommends the things we discussed. Dress in light layers, make sure your night clothes are light and wicking material, use an electric fan. You can keep cool water beside your bed at night, take a bottle of water to bed, and some people will even take a cold pack to bed with them. Again, essential oils like aromatherapy can help. Some women will take peppermint oil and rub it on their wrist and then sniff it to kind of break a hot flash. Soy and black cohosh are the herbs that people recommend to try to help with the hot flashes. Trouble sleeping, as we said, try to leave time for sleep and try to make your bedroom a place for only sleep and sex. Don't work in there. Don't run the TV all night. Have a quiet, dark environment. You can do milk before you go to bed, chamomile tea, relax and unwind. You can also, peanuts contain tryptophan as well. So peanut butter before bed, you can do that as well because tryptophan is the chemical that helps you fall asleep. Avoid caffeine and alcohol late in the day because they'll keep you awake. And in addition, they'll cause bladder spasm, which will make you have to pee in the middle of the night and interrupt your sleep as well. For sexual discomfort, sort of the theme of this is if you don't use it, you lose it. So you have to have sex. Even though it can be uncomfortable when you lose the estrogen, you have to think of ways to get around this. So really, the norm after menopause is bringing a lubricant with you for sex. So just have the lubricant there. You can use a water-based lubricant like KY jelly or Astroglide. You can use a silicone-based lubricant like Uberlube. And then some women just have discomfort in their vulvovaginal area down, on the outside of the vagina and the inside of the vagina, whether they're having sex or not. And for that reason, personal lubricants like Replens are really useful. They can keep everything moisturized so that when you're walking in your clothes or things aren't uncomfortable and dry.
So let's ask our audience another poll question. I want to know how many people, this is not the poll question, but how many people were doing their Kegel exercises when you were talking about that? I bet you most people were.
Lauren, you were doing
that's right. You can't help yourself. So what is the best hormone to treat for menopause? We've talked about some other natural things to do and some over-the-counter stuff, but from a hormonal perspective or a hormone replacement perspective, what is the best thing? Is it estrogen, progesterone, or testosterone? Dr. DeLuca's talked about all three. So let's see. 100% of our audience thinks that it's estrogen. So, Dr. DeLuca, can you walk us through if that is in fact accurate?
Yeah. I mean, systemic estrogen therapy remains the gold standard for treatment of hot flashes and night sweats. We call it vasomotor symptoms. And really, it's very effective at treating that. It can also help if you're taking systemic estrogen. It not only helps with your hot flashes and your vasomotor symptoms, but it'll also help treat the vaginal dryness we were just talking about. It can also help the long-term consequences, like help your bone loss and things like that. So estrogen is really the gold standard for treating some of these things. However, some women are not candidates for estrogen. And we know that women who have had a personal history of cancer, such as breast cancer or uterine cancer, are not candidates for estrogen. Women with blood clots cannot take estrogen because we know that estrogen can cause blood clots, so they're not candidates. Also, women with liver disease, because estrogen is conjugated in the liver and it is not recommended in liver disease. And in some women with heart disease, especially older women with heart disease, not recommended.
I'm sure there are many women who don't want to use hormones anyway, right? So are there alternatives to doing actual hormones that could help us as well?
There are. Estrogen in and of itself, as we just talked, it can help all those things, and it's contraindicated in certain things. But the thing to know about estrogen is that it's got a few risks, and that's it can cause blood clots, like we said. It can cause elevated blood pressure and strokes, and there's a slight increased risk of breast cancer. So some women are just not willing to, deal with those small but present risks. So they want to know what else can they do. So, a lot of people have talked about all the different herbal supplements that you can take. Black cohosh and soy, we said, people take for hot flashes. St. John's wort helps mood. Dong quai can also help with hot flashes. Red clover is a phytoestrogen, and that's the same kind of thing as soy and black cohosh, and it can help with hot flashes. Evening primrose oil people take for breast pain, especially perimenopausal breast pain. Milk thistle, sage, and maca root can sometimes also help with the symptoms of menopause. However, none of these herbs, even though they're widely used and widely marketed, and many women take them, including myself, have ever been shown to definitively work with hot flashes. So some people suggest that acupuncture is just as effective in alleviating symptoms of menopause as some of these herbs. Other things you can do, like we talked about, very, very effective to avoid simple sugar and simple carbohydrates. And, wine is actually got a lot of sugar in it. So while we feel like we really want to eat a brownie and drink some wine when we're going through all these menopausal changes, those are actually creating more hot flashes. You may notice if you have a big pasta dinner and a glass of wine, or if you have pizza, you're having more hot flashes at night. And that's because the sugar and the carbohydrates is actually contributing to the hot flashes. So I tell patients to kind of concentrate on a diet that has a lot of lean proteins and a lot of low glycemic fruits and vegetables. Like instead of doing pineapple and bananas, you may want to do berries, or instead of doing like beans and lima beans and corn, you may want to emphasize like broccoli, cauliflower, kale, spinach, things like that. You want to consider omega-3 fatty acids and oily fish, because those are really good for the heart. Things like whole grains, lentils, flaxseed, those are very good for the diet as well in menopause. And avoiding caffeine, sugar, and alcohol, like we said, that's definitely key, because those things will actually make the hot flashes worse. Regular exercise, as we discussed, really important. Stress management, if you find yourself in a very stressful environment, that's going to make your hot flashes worse. So trying to reduce the stress either with exercise or some of the yoga and different things we talked about. There are some non-hormonal options that people talk about when they talk about treatment for menopausal symptoms. And one of them, called Brisdel, is actually a low dose of the antidepressant Paxil or paroxetine. And while Paxil is used for depression, the 7.5 milligram dose, called Brisdel, is used for menopausal hot flashes. And it's really the only antidepressant that's been approved by the FDA for the treatment of menopausal hot flashes. So a lot of women will choose to do that. However, there is some associated weight gain with this drug, not so much at the lower dose that's used for the hot flashes. So some women are not okay with that. Also, if you're taking Celexa or Effexor for your depression, it'll not only help your mood, but it can also help hot flashes. There's an old-time antihypertensive for blood pressure called clonidine that is not widely used anymore for blood pressure, but sometimes in refractory cases at a very low dose of 0.1 milligrams per day, it can be used for menopausal hot flashes as well, and does not really create a significant decrease in your blood pressure. So any of these things can be used instead of considering estrogen. But for some people who are just suffering, especially the hot flashes or the terrible mood swings, anxiety, they just can't concentrate, they can't sleep. Some of these these people will honestly be requesting hormone replacement therapy, and it's appropriate for them. And you may have heard of bioidentical hormones. And what that actually means is it's the same kind of hormones that your own body makes before menopause. So we're talking the ovary makes estrogen or estradiol, progesterone, and testosterone. And those are bioidentical hormones. Bioidentical hormones for replacement, there's a number of choices that are FDA approved and can be used widely and safely. You can take estradiol in an oral tablet, and that would be like Estrace, or a skin patch, Vival Dot, Menostar, things like that. It's like if you've ever heard of somebody having a smoking patch, a nicotine patch, it's the same thing. You wear it on your skin and change it once or twice a week for estrogen replacement. There's also sprays and creams and gels that you can rub on your skin. And there's some suggestion that the transdermal preparation of hormones is a little safer for women. So things like Estrogel, Divigel, Evamist, things like that can be sprayed or applied to the skin for bioidentical hormone replacement therapy. There's a vaginal ring called the FemRing that you actually insert in your vagina, and it stays in there and provides systemic hormone replacement therapy. These things are all systemic. They go through your whole body. Progesterone right now is necessary if you have a uterus and you are interested in estrogen replacement therapy, because estrogen is not safe for the uterus, so it has to be taken with progesterone. Progesterone is the bioidentical form of what our body makes, and it's only available in an oral tablet right now. However, there's a brand new medication on the market right now that contains estradiol, the bioidentical estrogen, and progesterone, the bioidentical progesterone, in one tablet for women who want hormone replacement therapy and have a uterus. And it uses coconut oil instead of peanut oil, so it's safe for our patients who have peanut allergies, and that's called Bijuva. So that's a more convenient way to take the bioidentical hormones. The other thing that people talk about when they say, what is the difference between systemic hormone replacement therapy and just vaginal estrogen? And some of our patients just have vaginal symptoms. They don't really have hot flashes that are debilitating, or they don't need, or are nervous about taking systemic hormone replacement therapy, which carries those risks of blood clots, stroke, and breast cancer, like I was mentioning. So vaginal estrogen has not been shown to have any of those risks. Vaginal estrogen in the studies that have been done, and actually there's a really, really good webinar on YouTube from the North American Menopause Society on both bioidentical hormones and the genitourinary syndrome of menopause. So if you wanted to look that up on YouTube, you could get more information. But the blood levels of the vaginal estrogens are similar to placebo, meaning they really don't achieve a blood concentration, so they don't contribute to any of these side effects, these serious side effects that we talk about. You can use vaginal estrogen just for sexual symptoms and for discomfort in the vagina. And we use creams like Estrace or Premarin cream. We use tablets marketed as Vagifem. There is an insert that's new called Imvexi. It's got a coconut oil vehicle, and it's just a little soft tab that you just insert with your finger in the lower third of the vagina. And there's also a ring that you can put inside for 3 months at a time called the East ring. All these things provide vaginal estrogen only. They're not going to be effective against hot flashes, but they are going to relieve some of these symptoms that women are having that are preventing intimacy. For women who don't feel that they're safe for any kind of estrogen, there's also a vaginal steroid called Intrarosa, and it's made of a steroid called DHEAS and gets converted into a very small amount of testosterone and a very small amount of estradiol. So that's also bioidentical as well. And then there's an oral medication called Osphena that doesn't achieve a blood level, but again is only used for vaginal symptoms. So these are some things that women can consider if they're considering, obviously if you're anywhere on the spectrum where you're just having mild symptoms or, just want something that'll just be natural over the counter. up to women who are having severe symptoms and really want to consider either systemic or a local treatment for some of their terrible symptoms.
Wow, that's great. Thank you so much. We're going to open it up now to some questions and answers. You've provided us a ton of information, and we often have some questions related to some of the information that we provide. So the first question that we have are there things that can be done to delay the onset of menopause?
Oh, wow. No. I mean, in the truest sense of the answer to that, if you are taking the birth control pill in your late 40s, that is actually hormone replacement in a much higher dose than the menopausal doses that we're talking about. So some women will stay on an ultra low dose birth control pill until they're 50 and will not even be aware that they have gone through menopause already, because they're taking hormone replacement, they're taking estrogen and progesterone in their birth control pill. But we all are programmed to go through menopause when we're programmed. So by the time we're born, we have all the eggs in our ovaries we're ever going to have, and then we lose a half of them at birth. And every single month after puberty, we lose a whole bunch more at puberty. Every single month after puberty, we're losing more and more of our ovarian reserve. And every woman is programmed to go through menopause when they're programmed to go through, and some, runs in the family and things like that. So I don't know that there's anything you could do to delay it other than, like I said, taking the birth control pill or hormone replacement therapy. It's not that you're delaying your ovaries from stopping working. It's just that you're delaying noticing that your ovaries have stopped working.
So you mentioned that people can do that till age 50. Is that the general sort of break-off point where you can no longer then take the oral contraceptive pill for that?
That's a really good question, and that's also controversial. I have colleagues who prescribe oral contraceptives in the early 50s. I personally was always taught that you stop around age 50, and you really, it's such a high dose of estrogen. It's much, much higher than the dose of hormone replacement therapy, that it is a risk for breast cancer, blood clots, and stroke once you get into your 50s. So each provider kind of makes their own line in the sand. There's no guideline, but I think a lot of us feel that 50 is the cutoff for birth control pills. Okay. At least estrogen-containing ones.
Right. The next question that we have is, I'm a breast cancer survivor. Is vaginal estrogen an option for me? Because I've heard it's linked to cancer.
That's a really wonderful question. And, again, I want to direct you to the NAMS YouTube conversation on the genitourinary syndrome of menopause, because it really is wonderful. But all the studies have shown that all of the vaginal estrogen products do not achieve a blood level that's any different than placebo. So what that means for a breast cancer survivor is there's not going to be any estrogen in her blood in an appreciable amount that would stimulate her breast to cause more cancer. But some breast cancer is one of those things where we don't prescribe estrogen. So if a breast cancer survivor was interested in a vaginal estrogen product, that would definitely have to be a conversation with her oncologist before she starts. And many times the gynecologist and the oncologist talk together about the patient and make the decision. There is that product that I was talking about, which is DHEAS, which is a vaginal steroid. And again, like I said, it gets converted into a small amount of testosterone, which can help libido, and a small amount of estrogen, which is way smaller than any of the other estrogen products. And some people feel that that is really the treatment of choice, the intrarosa, which is that it's like a little pellet that gets injected every night to help with vaginal dryness. They feel that's really the treatment of choice for our patients that are breast cancer survivors. But again, I've had breast cancer survivors that after conversation with oncologists, we've decided that the best thing for them is to take a little bit of estrogen cream or a little bit of a estrogen pellet in the vagina, and they've done very well with that.
Let's take another question. On average, how long does menopause take to go through?
I wish I knew. They say, anywhere between 4 and 5 years, but it's anywhere from, 1 to 2 years, all the way up to 10 to 15 years. I mean, I still have some patients who are 70, 80 years old who beg me for hormones every single time they come to the office. And
I can understand why.
I mean, back in the day, they used to just put women on estrogen after the change of life and just leave them there forever. And I once had an 85-year-old woman who had refused to give up her estrogen call me and say, "I just got a blood clot. Should I come off the estrogen?" And I said, "Yes, you should. You should throw it out, burn it, get rid of it." But, people are married to their estrogen because this process can be a lifelong thing. Most of us between 2 and 5 years, I would say.
Right. Thank you. So I do want to thank you for joining us tonight. And I hope that our audience has a better understanding of menopause and what you can do to help alleviate some of the symptoms that we experience as a result of our estrogen levels decreasing as we age. Inspira Medical Group is very proud to have Dr. DeLuca as a member of our family of accomplished providers. She's available to see patients at the Inspira Medical Group OBGYN practice in Mullica Hill, West Deptford, and now, as I mentioned earlier, in Washington Township. He's seeing patients in person as well as providing telemedicine services. I do want to tell you that we have another Spirit of Women webinar on December 1st at 7 o'clock. It's entitled Mixing It Up to Reduce Stress. If you're interested, go on our Spirit of Women website and you can register. We hope that this webinar will help us deal with all the stress that we experience in our daily lives, especially during these challenging COVID times. So also, as you know, all these programs have a lot of planning and teamwork that gets done behind the scenes. I'd like to thank Suzanne Plaskett-Bauer and Lauren Clinton for helping us to put these programs on for you. They do a lot of work behind the scenes to make it look seamless. And remember, especially during this sort of uptake of COVID, stay home when you can, wash your hands, wear your mask, stay 6 feet apart so you can stay safe. And thank you for participating with us tonight. And Dr. DeLuca, thank you again for joining us and helping to educate our women. So thanks
for having me.